Hi, welcome back. This is Dr. Stephen Allison, ophthalmologist. I'm here to give you some pointers as to more of the basic approaches to an eye and the examination and treatment of some common diseases. Now, the most important thing is when you approach someone with a red eye is to remember two important things. A, that the basics still apply. The basics of any examination still apply. So don't forget it just because it's an eye. Don't be scared of it. Don't be trepid. Don't do any of those things. Just go for it and do the things you would as you would examine anything. That's number one. Number two, what's very important is that the 80-20 rule applies in medicine very often, and especially in an eye and in any of the specialized sections that you think are too difficult to cover. If you know 20% of the trees in your area, you'll know 80% of the trees you'll ever see. When you lay a carpet, 20% of the carpet gets walked on and 80% is pristine. And so the 20-80 rule applies, and the 20-80 rules applies in medicine as well, is that if you know 20% of the things that can go wrong with an eye, you'll probably be right 80% of the time. So what a pleasure. You just get those 20% really, really good. Then you know if it's not part of the 20%, it's you need to refer the thing, but you'll be right 80% of the time. So only 20% of the time will you need to refer and not be able to treat them yourself. So important principles. First of all, always try and structure your examination protocol. But this is not just for the eye, this is medicine in general, is subjective, objective, assessment, and plan. There must always be a plan at the end. And subjective is very important. We tend to flip past that. That is, how does the patient see all of this? No pun intended. How, or not see it in this case. How does the patient will tell you. If you allow him, the patient will tell you. You must just allow the patient to give you the information, lead them a little bit, make provisional diagnoses, but subjective is important. So when you're approaching an eye, you need to know what happened. Was there a history of trauma? Was it unilateral? Was it bilateral? Does it affect his vision? Is it seasonal? All the basic things, and always try and make a provisional diagnosis. For example, if you think it's just an allergy, then talk to him about allergies. Say, listen, do you have dogs and cats that sleep on the bed? Do you have a bird in the house? Do you sleep on a feather pillow? Does he have feather duvets? Does he have sinusitis? Is the sinuses a problem? Does he have asthma? Does he have hay fever? Because the allergic triangle is right there by the eyes. And that leads you to that thing. If the red eyes occur seasonally only when certain trees are flowering in his garden, obviously it's allergy. And there you've made the diagnosis without even looking at the guy, just by a good, decent interview. Second things, trauma. Was there trauma? Was there no trauma? Was it minor trauma? Was it major trauma? Was it associated with other problems that could have happened? How is his vision? And so on. So subjective, very important. Have a nice, solid interview with the patient, because that makes him at ease, and B, it gives you a massive amount of information that you can use then in your objective side when you start examining him, because you then sort of have made a diagnosis in your mind before you even examine. You're actually examining him just to confirm what you already know, rather than to try and find out what happens now. So don't dive into observation before your subjective part has been done properly. Right, so now when we get into the examination, all of us think, oh, we haven't got fancy equipment. How can I examine this eye? I'm in Upper Gulf Bulawayo. I don't even have a decent ophthalmoscope. How am I ever going to make a diagnosis? What's wrong with this guy's eyes? He's got this swollen red eye. Don't know what to do. Now, it's very, very simple. You need some very, very basic stuff to do massive, beautiful, excellent academic medicine. One, you need something red, like the red bottle, or just red, any old red. So you need red for color vision. Very important. Red for color vision. What do you need? You need a light source. That's all. Just a light source. It doesn't even have to be an ophthalmoscope. Ophthalmoscope would be fine, but it serves as a light source. Very, very important. You need a Snellen chart. We've spoken about that, just to get some objective things going with VA. But these are the basics. Things like corneal sensation, you test with a napkin or with a piece of toilet paper. You measure proptosis with an old sushi stick that you've just measured. I'll go through all of that with you. So as you can see, you need very little. What I've always said is the most important part of a stethoscope is the part between the two earpieces. It's not how good the stethoscope is. Stethoscopes will help you nothing. It's what happens between the two earpieces that's very important. So, objective, what do we do? Of course, the first things first is functions. We've spoken about that. You need to do the function. You need to sit the guy down 6 meters away and test the eyes. Test the one eye, then test the other eye. With the spectacles, most important. So vision is very important. Is there good vision or isn't there good vision? Because that separates the men from the boys. Somebody with a red, painful eye that's blind or that has poor vision is much more in trouble than a guy that's got normal vision with a red, painful eye. So very important. Get the function sorted out. Right down to hand movements, finger counting. Remember, always make the guy take off his specs and check whether he's got light perception, whether he's got finger counting, whether he's got hand movements, and write all that down because that quantifies it nicely in your file. Then you go down to no light perception. We've spoken about that being a massive diagnosis because the optic nerve is a central nerve, and once it's dead, it's dead. So very important to make sure that you get a good function going. Once you've gone right down to that, what's very important is to check the guy's color vision. Color vision, take a red object, any red object, and you say, what do you see? You cover the one eye and say, give this to, this is now the relatively normal eye. You give this 10 out of 10. Give him 10 out of 10 red. It's 10 out of 10 red. And then you give him the other eye and you say, is it still 10 out of 10 red? And you're not going about, is it red or not? It's about the hue of the red. In other words, has it been washed out a little bit? In other words, is the one eye seeing this and the other eye seeing this? That it's a little bit washed out, that it's a little bit pink. And if he says 9 out of 10 red or 5 out of 10 red, it's not as good as the other one, it means his color vision is gone. And color vision is a very, very, very delicate and very, very detailed function meter of your macular function. So if someone's a diabetic and he's got a red eye and he's got normal color vision, his macula is probably working. He probably doesn't have edema in his macula. So color vision is very important. The hue of the color, not does he see color or not. So the hue of a red color. Pupil reaction, of course, is very important. Direct reflex, okay, direct reflex, consensual reflex. Your swinging flashlight test, Marcus gun, hey, to make sure that he hasn't got an optic neuritis, all right, or an optic nerve problems. Marcus gun's very important. Near reflex is very important. Follow my finger, right, and see whether the pupil gets smaller. Very important, so that you do light near dissociation, as we've spoken about in neurosyphilis and so on. And then the last one is very important, but we'll get onto it in more detail, is corneal sensation. Test the guy's corneal sensation, because it's going to, you're going to see now why. How do we test corneal sensation? Say, no, this eye is the red one, and this is the one he's complaining about. This one is the relatively normal eye. So what do? You creep up on him from the side, okay, outside his field of vision, so he doesn't know you're coming. He doesn't know you're coming, and you go forward, and you touch his cornea, boom. And you see what his pupil, what his palpable reaction is, and he's gonna close his eye. So you can see, is it a sluggish or is it the right one? So you've got the speed at which he closes his eye when he reacts to the cornea, when he reacts to the touch on the cornea, and then you creep up on him from the side in the other eye, and you just touch that cornea, and you'll see it's much more sluggish than the other eye, perhaps, or it's exactly the same as the other eye. Very, very important thing. Corneal sensation. We'll talk about that now. Right, when that's now just the function, that's getting the function going. When you examine the eye, it's very important to remember that it's part of the body, that the rubor, calor, dolor, tumor, functio lis all apply. Those rules of inflammation apply. Is it swollen? Is it painful? Does it have a discharge? Does it not have a discharge? So that's very important to remember that it's the same things that apply. When you look at the conjunctiva, is it the whole conjunctiva that's red? Or is it just the area around the pupil, around the limbus that's red? Is all of it red? If you open up the lid and you see inside, you see the whole lot is red, it's probably a conjunctivitis. If none of that is red, but the eye is red around the limbal area, then the pathology is probably coming from inside the eye and not from the outside, and so on. So think anatomically. Go forward, think anatomically all the time. All right. Now the next. Let's sort of systematically go through some of the more common eye problems that you're going to see and how to approach them, that they're not scary. The most important one that could be a scary one, or that is a difficult one, is an orbital swelling. If there is orbital swelling, in other words, the whole of one eye is swollen, the whole thing is swollen, it may even be swollen closed. That is just so scary. You don't know what the hell's going on, especially if it's a child. There's the swelling. You've asked in the history. He says he had no trauma, or he had a little bit of trauma, or he thinks he's not sure what happened, but this is swollen, and it's just a mess. And so what do? You must. The first thing that's very important in an orbital swelling, extremely important. If there's a history, we're going to talk about that when there's been a bash on the eye, is the most important thing. If there's an infection, if there's a discharge or any of those things, is to make sure that this thing is either preseptal or postseptal. In other words, is this in front of the septum, which guards the eye, or is it behind the septum? And the only way to know that is if there's proptosis present. If there's no proptosis, in other words, if the eye itself is not pushed forward, it means that all your inflammatory process is in front of the septum and you're not in trouble. It's something that will probably subside with normal antibiotics, normal follow-up, normal problems. Once it's post-septal, once it's behind the septum, you're in trouble, because you're close to the orbital fissure, you're close to the lamina cribrosa, you're close to the brain, basically. And whatever's in there is either going to crawl into the brain or is coming from the brain. So it's very, very important to test whether someone has proptosis or not. Now you say to me, now how the hell do you do proptosis? I mean, come on, I'm I'm certainly not a specialist in this. How can I do it? Very simple. And I don't have the instruments. You do have the instruments. Here's the instrument. The old sushi stick that you've cleaned very nicely, and you've measured the point at 20 millimeters. You take a normal ruler, 20 millimeters from the front of the stick, and you make a little circle, and you make a little line there. Okay. So what do? You turn the patient to the side. You touch the lateral orbital ridge with a point, and you see how far the eye is from the lateral orbital ridge. If it is in front of your mark, in other words, if it's more than 20 millimeters, trouble, probably proptosis, okay? But what's more important is to compare the normal side with your sick side. This is the normal side, that's the 6 query proptotic side. You test this one, you see, it's about 18, just below the 20 mark. And if this one is similar and also below the 20 mark, then he hasn't got proptosis. What a pleasure. Because remember, in some African tribes, it's very, very common to have a normal eye of about 21, 22. So it's not really proptosis until you've compared it to the normal side. As always, compare it to the normal side, but below 20, no proptosis. More than 20, proptosis, be careful. It's post-septal and you're in a bit of trouble. So proptosis. So you can all know how to measure proptosis. Write it in the file. When you phone a guy to say, please, this guy's got proptosis, he's got an orbital cellulitis, but with proptosis, if that specialist or whoever you're phoning doesn't react and say, send the guy immediately, he doesn't know what he's talking about, and you find yourself another guy to send him to. But don't try and treat it on your own. Try and get him to a specialist area, because post-septal cellulitis is a problem. Right, then we get on to another common disease is that can cause orbital swelling or swelling on the one side is someone that says he thinks a spider bit him in his face, because he's got these little pustules on his forehead. When he combs his hair on this side, or her, when she combs her hair on this side, it's painful. When she combs her hair on this side and this side, it's not painful. In other words, there's sort of a hypersensitivity of the skin in this area, and he's got this rash. That's probably a spider bite, he says. Now, I have, in 25 years of experience, never seen someone bitten in the face by a spider. So that just simply doesn't happen. It's not true. It's happy zoster till proved otherwise. In other words, it normally respects the midline. It only has a rash on the one side. And be careful, this could be herpes zoster, which is the old herpes varicella, which is the old chickenpox virus that has come back in times of stress. Comes back, it very often comes back on the body, which is shingles, and also respects the midline, but it can also happen in the face. And remember, it's the 3 divisions of the fifth nerve, trigeminal nerve, 3 divisions: ophthalmic division, maxillary division, mandibulary division. So it's in one of those divisions. It's very seldom in all 3. It's almost always in one of the divisions, and very often in the ophthalmic division. So it will always respect the midline. It will go only up to the sort of brow area. It won't go across, and very typically is very, very painful and uncomfortable for the patient. Now, one very important thing is, has it crawled into the eye? Because remember, the trigeminal nerve not only gives sensation to the face, but also gives sensation to the cornea. So it has a branch that goes to the cornea. So that same virus that has crawled up the nerve that's now giving the trouble on the face can also give trouble on the cornea. So, and that's very important to know. So you have a look, he's got a reddish eye, but is this really a problem? Very often there's a sign, or there's a very nice little clever sign. It's called Hutchinson sign. Now, Hutchinson sign is basically when the tip of the nose is involved. As soon as the tip of the nose is involved, if you have a little pustule on the nose, that same division that goes to the nose normally goes to the eye. So if Hutchinson sign is positive, be very careful. It's probably in the eye and probably needs help. Okay, from an eye guy. So that's very important to remember. With zoster, not much you can do, especially if it's not in the eye. What you need to do is not treat the skin lesions with something like calamine or one of those that just take away the pain, because they create fibrosis. Fibrosis creates neuromas and neuralgia, squeezes on the nerve. It has a circular, it very often can be a circular fibrosis around the trigeminal nerve, squeeze on the nerve when it actually heals, and the guys get neuralgia so badly that they can commit suicide because of the pain. So even though the disease is gone, you, by not treating the skin properly, have given it a trouble. And so the best way to treat is antibiotic, cortisone cream. Hair should be standing on end. I'm saying cortisone in the presence of a virus. Yes, I'm saying that because the cortisone is good for the skin's healing process, that there isn't too much scarring that happens. It's to prevent scarring for later. Remember, no cortisone in the eye, not for the uninitiated. The ophthalmologist will make that call if there's a problem and if it's needed, and the antivirals, of course. All right, now one of the more important things with zoster, of course, is not what's happening here, is why is it there, is the big 5. No? It's very important. HIV, TB, diabetes, thyroid, and then social problems. So some or other stressor is causing this, and it's up to you to find that stressor. So go and have a look for that stressor and treat the stressor and not just treat the end result. Right, so now the next one that we get to Trauma. This guy's had trauma. He was playing a ball sport. He was playing tennis, or he was playing something. They were throwing the ball at one another, and he got a bang on the eye. Right, and he comes into casualty, and he's got this swollen eye with lids all swollen, and there's trouble here, and you now have to make the call. What's very important is to make sure that if you can open the eye, see if there's a good reflex. Be very gentle with the patient, but very often they don't allow you. So what you need to do is you need to look for other clues that tell you that this guy's okay or he's not okay. And your big thing here is orbital floor fractures. No? Okay, blowout fractures is what's your problem. Is you need to make a diagnosis of a blowout fracture, or at least be suspicious of a blowout fracture. Now what happens? That's the floor of the orbit that goes. Now the nerve that goes on the floor of the orbit is the infraorbital nerve. Comes out here on the lateral 2/3. Comes out here on the lateral 2/3 of the lid, and gives sensation to this area of the cheek. So if your orbital floor has been damaged in some way, he'll probably be asensate in this area. So you do a little test with your sensometer, which is just a little bit of cotton wool, and you tell him, keep your eyes closed. Can you feel that? Can't you feel that? Can you feel that? Can you feel that? Can you feel that? Can you feel that? Always try and catch the guy out, because he looks a little bit and he's sort of tries and uses secondary clues. You want to know absolutely, has he got some sensation there? If he's got sensation, he probably doesn't have an orbital floor fracture, because that nerve didn't get damaged. If you can, the eye movements are also inhibited, up gaze and down gaze. Remember, if the inferior, if the muscle on the inferior side has been entrapped into the floor fracture, then he has an inability to look down, but it also restricts the inability, and it also has an inability to look up. So if he has an inability to look up or down, think about an orbital floor fracture. I must say it's very difficult when it's very, very swollen, and very often not so easy to diagnose. The other thing to use to know whether there was maybe a base skull fracture is the raccoon face. Is as soon as there's bleeding from the ear, or the raccoon face where they look like a raccoon, where they've got a really bad hematoma below the eyes here, then that means there's probably been base skull trauma as well. So be careful of that. All right. So trauma is easy. Up or down gaze. Make sure that he has sensation on the inferior side of his cheek, and send him for X-rays for base skull fractures. Okay, for not for base skull fracture, but for orbital floor fractures. Remember, base skull fractures in someone with a raccoon face. What's very important as well is if there's no history of trauma, no history of spider bites in the face, no history of any of these problems, and the guy has just woke up one morning and he's got this swollen eye, so swollen that he can't open it, and everybody's scared that he's going to lose his eye and do all sorts of things. That is probably early meibomianitis. Early meibomianitis, in other words, one of these meibomian glands in the top or the bottom have become infected, and they very often swell very, very dramatically. So be careful, have a look, open up the lid, see if you can't see the white of the meibomian opening, which is right on the grey line, just beyond the lashes. Isn't there a little area of pus sitting there, which is the dead giveaway? That needs antibiotics, needs some warm compressions and so on to make it go, or needs drainage. So very important to remember that if you want to drain a meibomian abscess, never drain it on the outside unless it's really, really severe. If you do drain it on the outside, you've got to give a horizontal incision. Not a vertical, a horizontal incision. You've got to go with the lines of Langer, In other words, not against the orbital muscle, the orbicularis muscle, but with it. Otherwise, it splays open and they get a terrible scar. So the best thing is to turn up the lid and do a vertical incision, because your meibomian glands are sitting vertically. All right, but that gets a bit fancy. If you don't feel up to it, send it to someone that can do that. Then the last one that has to do with eyes that are bulging forward is someone that walks into your office, normally bilaterally. One side can be worse than the other, but they've got Dalrymple sign, which is someone that has just got money back from the taxman. He looks like, wow, I just got money back from the taxman. My favorite team just won. They fixed the potholes in my road and I didn't even moan about it. All the robots were working on the way to work. My boss was nice with me today. He's got that look about him, that surprised look, because what happens with thyroid eye disease is that the eye pushes forward. Okay, there's mucopolysaccharide buildup in the fat around the eye, and it pushes the eye forward slightly, so much so that the upper lid pulls up a little bit. And the normal is that 2 millimeters of the superior limbus is normally covered with an eye. When that doesn't happen, when you see the white, the sclera of the eye above the limbus, especially at the top, it's probably a Dalrymple sign, and you need to test for thyroid. What often happens in thyroid eye disease, it can also be that his thyroid is normal, his thyroid function is normal, but I've seen in my experience, it very often is a precursor to thyroid problems anyway. So even if the thyroid is normal, be careful, it's probably still going to be abnormal and you need to start treating, or you need to send him to someone. But don't miss that sign. When someone is surprised and they walk in and they're all surprised, and especially if they're a bit jittery and they move and they're fidgety and jittery, they've got high thyroid and you need to sort that out. Then it's not an eye problem, it's a thyroid problem. And how do you test for a thyroid? Is you need to go from behind, you hold the guy's neck and you say swallow. And if you feel a bump moving up and down with swallowing, that's the thyroid. It's very simple, but you can't feel it from the front. You have to go behind the guy, stand there, say swallow please. When they swallow and you feel a big lump moving up and down, it's a thyroid. Right, so that's proptosis sort of in a nutshell. There's many other things that can cause it, but those are the big ones, and those are the ones you've got to be careful of. Now we get on to pink eye. In other words, there's no proptosis, there's no swelling around the orbit, and there's no lid problems, but the guy has got these pink, pussy, painful eyes. Okay, pink eyes. Now, pink eye is basically a colloquial term for red eyes. That's just not so red. So it's not a diagnosis. Pink eye is not a diagnosis. Pink eye is an observation. And it's up to you. You don't write in someone's file, I think he's got pink eye. That's stupid. That's just not, that's academically insecure to say that. So what you need to do is, if someone comes in with pink eye, you need to say, okay, what is this? Is this an allergy? Is this a viral? Is this a bacteria? Those are the big three, basically. So number one, allergy, you've actually sorted that out with your history. You've already seen, is it atopic? Is it seasonal? Is it in the allergic triangle? Does he have hay fever? Does he have all sorts of other allergic things? And then it's probably the pink eye is caused by the allergy, and you should sort that out. Now, if he doesn't have any of that, and you say, and you think it's a viral infection, what does a viral conjunctivitis look like? A viral conjunctivitis is really a pink eye and not a red eye. So it's not terribly red. It has some swelling. Very often, because the guy rubs, you know, remember, if something's allergic, he has a sand sensation. It's not a burning sensation, it's a sand sensation. If someone's got a sand sensation, feels like someone threw sand in his eyes, that's probably an allergy. If someone's got a viral, it's not such a bad sand sensation, they've just got an irritated eye. It's not really burny, but it's irritated and it's not comfortable. There's a discharge, but it's a watery discharge. And, and of course, the function is normal. You can see well, everything's well, but he's got this red eye. What's very important in viral conjunctivitis is that the preauricular node is very often involved in a virus. Remember, this is going to sound funny, but in a virus, the preauricular node is swollen. So always just run your finger to the preauricular node, and you'll know this is probably a virus. If it's got a watery discharge, preauricular node that's swollen, probably a virus. It's an adenovirus. It has no real treatment. and it's self-limiting. The only problem with it is it's very infective. It's an infective thing. So he needs to wash his hands. He needs to not not wipe his eye with a handkerchief, put back in his pocket, and then wipe his eye again and put back in his pocket and wipe it back. He needs to wipe it once, throw away, take a new one, wipe, throw away, so that you can minimize the viral load in that way, and of course not share baths with anybody. Save water and bath with a friend. In this case, you mustn't save water and bath with a friend. In this case, you must be separated. No sharing of towels, no sharing of face cloths, no kissing and cuddling of children, and so on. Right, if it's bacterial, perhaps. If it's bacterial, it's a little bit different. It's more red, it's more painful, and it has a pussy discharge. Pussy discharge, because it's normally a staphylococcal infection. Staphylococcal infections are all pussy. They are a pussy discharge. Staph epidermidis is one of the most common ones. Staph aureus, and they have a pussy discharge, and you can of course send it away for testing. Take a little swab, send it away. It's good for that, but start some antibiotics going there. All right, and of course your preauricular node will not be involved. So you have this pussy red eye, no preauricular node, probably bacterial conjunctivitis. Still not a big deal. Now let's get on to if there's a corneal ulcer. In other words, if you look at the cornea and you see there's a little white spot. So you've got this pussy discharge, but you also got a white spot on the cornea. This is not just a conjunctivitis anymore. This is a corneal ulcer, a little white spot on the cornea. Now, a white spot on the cornea, now you're in trouble, because this bug has actually penetrated into the cornea. Now your big decision is this a dendritic ulcer or is this a bacterial ulcer? Very, very important. What is the difference between an early dendritic ulcer and an early bacterial ulcer? What's very important, I always say, what you must, whenever you think about diseases, is think about the pathogenesis. Always think about how the disease got there. How did it happen? Because then you can, with a retrospectoscope, push back and find the cause. And when you have all of that, you know that you just need to treat all the things along the way, the steps along the way, if you understand the steps. So a viral corneal ulcer gets there via the trigeminal nerve. In other words, it crawls up the nerve and then gives him the dendritic ulcer, or one of which is simplex, the simplex viruses. Or it could be a zoster that has gotten into the eye. You get the corneal sensation in those eyes will be decreased because the trigeminal nerve has been damaged on the way up. Bacterial corneal ulcers came from the outside. It's something that was introduced into the eye, so it has nothing to do with the nerve. So your corneal sensation in a bacterial ulcer will be normal. So there comes your test. Remember we spoke about it earlier. Your corneal sensation, here's the sick eye, there's the good eye. What you do is you creep up on the good eye, you see what his reflex is like, you come up to the bad eye, you touch it, and he sluggishly closes it. It's probably a viral. Why is it important? And if it was bacterial, it would be similar to the other side, or even enhanced. Why is it important to know that? Because in bacterial corneal ulcers, you can get away with giving steroids, antibiotics and steroids. In a viral corneal ulcer, steroids and antibiotics are contraindicated. In other words, you are going to make it worse by treating it. So you've got to know, before you go over to treatment, you've got to know, is this a virus or is this a bacteria? And remember, this is very important for me, is primum non nocere. First, do no harm. So if you don't know, don't treat. Don't think, the bigger the doubt, the bigger the dose, doesn't apply. The bigger the doubt, the bigger the hammer, doesn't apply. If you don't know, don't treat. So, and in this case, you don't need fancy stuff. You need to just test his corneal sensation know that there's a white dot on there. This is probably a virus. I'm certainly not going to give steroids. I'm not going to give antibiotics. I'm going to refer this guy to someone that knows what they're doing. Or if you're in a very far area in Upper Gulf, Bulawayo somewhere, you know at least don't treat with antibiotics and steroids. If you want to, you can put a bit of antibiotic if you're unsure, but start the antivirals and follow the guy up. Corneal sensation, very, very, very important in the evaluation of a red eye, especially if there is a suspicion of a corneal ulcer. Right, that's enough for now. Join me in the next video when I go through a couple of more interesting eye diseases that cause a red eye and can give you trouble in the treatment, and I will sort them all out for you. See you then.